COVID-19, and with the new wave is approaching, so this is basically the demand of the time. That is why, on the request of all our fellows and our residents and students, basically this is the extra. So with the request of our fellows, our DNB students and other students, basically we are going to do the today's webinar on a very interesting topic, COVID-19. And the today's speaker will be Dr. Lakshman Jasani. So Dr. Lakshman Jasani is working with us, Apollo Hospital, Navi Mumbai, and he is the infectious disease specialist. He has done his DNB General Medicine and FNB Infectious Disease, and he has also done the fellowship from the UK. And with us, the other eminent faculties or the panelists like Dr. Charudat Baitis. He is basically the Associate Director, Critical Care Medicine, Fortis Hospital, Mumbai. And Dr. Ketan. Dr. Ketan is Consultant Intensivist, HN Hospital, South Bombay. And with us, our one of the eminent faculty from abroad, Dr. Diptesh. So Dr. Diptesh is basically working as Dr. Diptesh Aryal is basically working as an intensivist, research physician, NICRF and MORU Hospital, Nepal, and he'll be joining us from Nepal. And with us, our own panelist, Dr. Santanu. Dr. Santanu is working with us in Apollo Hospital, Navi Mumbai. And myself, Dr. Gunadhar, I'm the senior coordinator and consultant intensive care, and my colleague, Dr. Achilles. So we welcome you all to this interesting webinar, and I request you to put all your questions in the chat box. At the end of the talk, we are going to take some questions. So I hand over the mic to Dr. Lakshman. So please start the session.
Yeah. Thank you, Gunadhar, for the very kind words. So friends, today we are going to discuss about COVID-19, and what I will go through is basically some basics about COVID. What are the clinical features? What is the treatment, the infection control aspect, few slides on vaccines, and something about post-COVID complications. So let us start with the virus. So the coronavirus, as we know, it belongs to a family of respiratory virus, and it is called corona because there are crown-like spikes on its surface. So because of its appearance of crown-like spike, it is called as coronavirus. And of course, we know coronavirus is notorious to mutate quickly and acquire new qualities. And the common coronavirus strains. So COVID-19 is not a new disease. COVID-19 is a part of coronavirus, and this coronavirus has been circulating in various decades amongst humans. And these are the various strains, as you can see, 229E, LN63, so on and so forth. And coronavirus is known to cause respiratory infection like mild cough, and it can cause severe disease as well. And this coronavirus has caused previous pandemics as well. For example, the Middle East Respiratory Syndrome and the SARS-CoV, the severe acute respiratory syndrome. The Middle East Respiratory Syndrome was an epidemic which was there in the Gulf countries, and the severe acute respiratory syndrome was the syndrome which was present basically in the China. So what is new about this COVID-19? So it is a disease which is caused by a new strain of coronavirus caused as SARS-CoV-2. This is how it was designated, and it was not previously identified in humans. And this coronavirus belonged to beta cov of the subgroup 2b, and it was the 7th member of the coronavirus family. So there was a mutation in the coronavirus with respect to its strain, and that is why it formed a new strain, which is we call it COVID-19, and we call it COVID-19 because it was first discovered in the year to December 2019. Now, genetic sequence mutation, more than 80% identity to SARS-CoV is there, and 50% identical to MERS-CoV. So it is similar to the SARS-CoV and MERS-CoV with its own unique mutation which is present. Now, what is the mutation which is present is basically there is a stabilizing mutation which falls on the endosome associated protein like the non-structural protein 2. And because of that, it has a high ability of contagious spread because it binds with the receptors very tightly. And because of this mutation in its binding, it is very highly able to spread very rapidly. There is this destabilizing mutation in the non-structural protein 3 proteins, which is the potential mechanism differentiating COVID from other SARS. So these structural changes makes it unique, makes it more easily transmissible. So how is the pathogenesis of this COVID-19? So as you know, the primary target of the virus are the lung epithelial cells. They bind to the receptor binding domain of the virus spikes and the angiotensin converting enzyme. So there is ACE2 receptor which is present in the lungs, and the COVID virus binds to the ACE2 receptors, and that is how it gets entry into the host cells. These receptors are present in high propensity in the respiratory tract and the GI tract. Patients infected with COVID-19 have high leukocytosis initially, and then following that they have a lower total leukocyte counts, but they have abnormal respiratory findings, increased levels of plasma pro-inflammatory cytokines and the chemokines which are present. So this is how we saw what is COVID-19, what is the virus which is COVID-19, and how does the COVID-19 virus causes pathogenesis. So coming to the clinical features, as we all know, there will be a high grade fever, there will be a prodromal symptoms like tiredness, and of course it will cause respiratory symptoms. And the respiratory symptoms begin with dry cough, which may later on progress to have productive cough as well. So the typical top 4 features of this coronavirus would be a prodromal symptom like tiredness, high-grade fever, dry cough, and which will progress down to the respiratory tract, and it will cause breathlessness, dyspnea, that is difficulty in breathing. Besides the respiratory symptoms like sore throat, rhinorrhea, pneumonia, and on CT, the ground glassing appearance and causing further progressing into the ARDS, there are certain systemic features as well as which occurs. So this coronavirus causes other systemic features like fever, headache. In some cases, it may form pulmonary hemorrhage and cause hemoptysis, acute cardiac injury, hypoxemia, diarrhea. So not only affects the respiratory tract, but affects the other systems as well. And what is the severity? It can vary in the severity, and the disease appears 2 to 14 days after the exposure. So the signs and symptoms, as I told you, similar symptoms between COVID-19 and earlier coronavirus with fever, dry cough, dyspnea, and bilateral ground glass opacities on the CT scans. The unique feature with COVID-19 is it targets the lower respiratory tracts with symptoms of upper respiratory tract, and in some of the cases infiltrates in the upper lobe of the lung on chest radiography is associated with dyspnea with hypoxemia. And because it also affects the other systems, so it also affects the gastrointestinal tract. So many of the patients may present just with diarrhea, and then later we come to know that they are COVID positive. That is because the similarity compared to the MERS-CoV as well. How is the course of illness? The current reported case fatality rate is anywhere between 1.4 to 2%. But when we talk about the Delta strain, the case fatality rate is even higher. It can go as high as 10% as well. But the current pandemic which we are seeing is more because of the Omicron strain, and this case fatality between the Omicron strain is just around 1.4 to 2%. Overall, the clinical consequences of COVID-19 ultimately more similar to that of a severe seasonal influenza. So the symptoms are more or less similar to the seasonal influenza of H1N1 which we see, but sometimes the case fatality rate can be much higher as compared to the H1N1. What are the age-related morbidity? So far we have seen 3 waves of COVID. First we saw in the year 2020, then the second wave in 2021, and then we saw the third wave in the early part of 2022. So in the first wave, which was predominantly driven by the Delta wave variant and by the original strain, the median age of the patient was 59 years. It was typically affecting the elderly, and there was high morbidity and mortality amongst the elderly, among those with pre-existing medical conditions. For example, if you are having diabetes, cardiac problem, bronchial asthma, COPD, those were the target. But as we came across the second wave, we saw that not only the elderly people are getting affected, the younger people were also starting to get affected, especially in the Delta variant. And we saw that the patients were predominantly male. Patients with severe disease were more older, or those with non-severe disease by a median difference of 7 years. So severe disease was more seen in older people, lesser severe disease was seen in slightly younger people, younger by 7 years of age. Moreover, the presence of any coexisting illness were more common among patients with severe disease than non-severe disease. So again, we saw the people who had more comorbidities, they had more severe disease as compared to healthy individuals. So if you look at the comprehensive review, the commonest symptoms what they found in this study was fever, which was there around 43.8% on admission and around 88% during hospitalization, and cough, and diarrhea was not uncommon, around 3%. So fever, cough, respiratory illness, and diarrhea, these were the common features. The median incubation period was around 4 days, but it could range anywhere between 2 to 7, even extending up to 14 days. On admission, ground glass opacity was the most common radiological finding on CT scan, which was seen, and no radiologic or CT abnormality was found in certain patients. So even the patients who had respiratory disease, some of them did not have this typical radiological finding, which was present as well. Lymphocytopenia was present in almost 80% of the patients. And this is the case fatality rate. So as you can see, COVID-19 falls somewhere between here, between 1.4 to 2. as compared to others. If you see, compare the MERS, you compare the SARS earlier pandemic, they had a higher case fatality rate, but the COVID-19 were not so having so much of a high fatality rate. It was more or less similar to a swine flu or the seasonal flu. Then comes the question, how is the COVID-19 transmitted? So we very well know the COVID-19 is transmitted to respiratory droplets. So these droplets are more than 5 micron in size, and they go anywhere between 2 meters or around 6 meters distance. So if you cough and approximately up to 2 meters, the respiratory droplets can fall and it can be transmissible. There can also be contact with the environment contaminated infectious secretions, for example, the sputum, serum, blood, and the respiratory droplets. There was a doubt whether COVID-19 was causing airborne transmission, and there was some evidence which was suggesting that it was airborne transmission, more so especially if the patient was intubated and was undergoing suction, or if they are giving nebulization, then the respiratory droplets were getting converted into airborne routes of transmission. And of course, then there is this super spreader status. The cases have been implicated to asymptomatic transmission, wherein people used to be the carriers of COVID-19 and they used to be transmitting the infection without themselves getting affected. But overall, we can say it's more of a droplet infection rather than an airborne infection. But this debate can always go on because the airborne route of transmission has also been documented in few of the cases. Then comes, what is this R naught? Now, R naught is a figure which shows that how the outbreak is likely to spread. So the higher number of R naught number, the R naught is higher, the higher the chances of infection being spreading. For example, if you look at the measles, the R naught figure for measles is 12 to 18, which shows that the infection can be very rapidly spread, especially measles being an airborne route of transmission. Similarly, when we come down to COVID, and the good thing for us is the R naught is only between 1.5 to 2.5. That means one individual will likely to spread the infection to almost 1.5 to 2.5 other people only. It is not going to spread to large number of people. Whereas if you compare with measles or chicken pox, one person can transmit the infection to many people at the same time. So in that way, we can say COVID-19 is causing respiratory droplet infection, is not having a severe transmissibility. The risk factors, yes, the risk factors are elderly age, so people more than age of 50 years of age and people more than age of 60 years, especially with comorbidities like diabetes, Parkinson disease, cardiovascular disease, COPD, bronchial asthma, chronic kidney disease, chronic liver disease. These are at higher risk for COVID-19. And of course, we as healthcare workers are also at risk for COVID-19 infection. Then this was the first case definition which was formed in the year 2020 by the CDC, which I will not go into detail. So basically this was more a surveillance case definition. So it basically compromised that if you have respiratory symptoms and you have a history of contact with any COVID positive patient, or if you have traveled from geographical areas, like for example, initial areas were classified as China, Iran, Japan, and South Korea. But later on, we know as the pandemic spread, almost any part of the world, the infection can be acquired from. So this was the initial case definition which was proposed by the CDC for the COVID-19 infection. So that then came into the COVID action 10. Now these were 10 points which is very important for you to especially manage any COVID-19 patient. Number one, hand hygiene by staff at all points is very important. N95, wearing a 3-ply surgical mask, which was very important. Keep at least an arm's distance, preferably 6 feet or 2 arms distance. But if not, then at least 1 arm's distance of 3 feet, because we know it spreads by respiratory droplets. Offer a 3-ply surgical mask to patients and relatives to prevent the transmission. Patients and relatives to wear the mask immediately. For patients with presenting a history of travel to any of these countries, detailed history and examination needs to be taken. All communications has to be transferred to your hospital nodal officer and transferred to the designated facility, whether it was a government designated facility or any private facility which was designated. And all surfaces to be cleaned by hypochlorite every shift, and masks to be disposed of properly as per the state regulation guidelines. So this was the COVID Action 10 plan, which was initially initiated once the COVID had come. And later on, this plan was expanded more as we saw more and more pandemic which was happening. Now, once we've seen what is COVID-19 infection, what are the clinical symptoms, what is the pathogenesis, how does it cause its complications, we come to the management of COVID-19. So friends, if you ask me honestly, there is no specific treatment for the disease caused by COVID-19. Treatment is mainly symptomatic and supportive, and it is based on patient's clinical condition. There are various investigational approaches to therapies. Like I will show you the few of the investigational therapies and the trials which we had used, but majority of them have been unsuccessful. So if you divide the treatment options in the current pandemic, now when I say the current pandemic, I'm talking about the third wave and possibly the fourth wave, which we are probably seeing the beginning of it. The current pandemic is more due to the Omicron variant. So unlike the first variant, which was the Wuhan variant, we saw majority of the elderly people getting affected. The second variant we saw was the Delta variant, which was especially in countries like India were affected mostly. There even the young people was affected, and it was more severe variant causing multiple complications. But the third wave, which we are seeing, and probably even the fourth wave, we are seeing the pandemic of Omicron. Now, when we say Omicron, we are talking about BA 0.2 to 0.3. But now in the fourth wave, probably we are seeing BA zero point 0.4 and zero point 0.5 as well, which are being isolated. So Omicron predominantly is a mild disease, and we don't need to be worried much about it. So if there is any patient whom you're suspecting COVID, for example, fever, coryza, sore throat, cough, dyspnea, or any of the features such as causing fever with chills, rashes, even causing myocarditis, stroke, encephalitis, or any sick contacts or residents in high prevalence areas, or if presenting with MISC or MISA, which is basically multi-system inflammatory syndrome in children and multi-system inflammatory syndrome in adult, or any acute febrile illness more than 72 hours. So you should suspect that there could be COVID in this particular patient. So what should you do? You should divide these particular patients into three categories: category A, category B, and category C. When I say category A means this patient should have a saturation more than 94% on room air. They should be stable hemodynamically, and they can be done on regular follow-up. So this category A are basically a routine OPD follow-up patients. So this category B then includes those patients who have a higher respiratory rate, who have a respiratory rate more than 24, and their saturation fluctuates between 90 to 93%, or they are the patients who require oxygen but not requiring more than 8 liters of oxygen. So if they require oxygen, it is less than 8 liters per minute, and their FiO2 is less than 40%, but they're able to maintain saturation between 90 to 93% on room air. So that will be category B. And of course, then there's category C. These are the most severe or the sickest patients. Now, these are the patients whose saturation falls below 90%. They require oxygen more than 8 liters per minute. They are the ones whose FiO2 requirement is more than 40%, and they will be hemodynamically unstable. The BP may be low. They may have ARDS. They may have multi-organ dysfunction as well. So coming back to category A, so category A are your people who are OPD patients with saturation more than 94, stable patients. You can further divide them into two categories. One, which are age less than 60 with no medical conditions. You can call them category A mild. And the second part of category A are the people who are above 60 and those who have medical conditions like cardiac diseases, liver, kidney dysfunction, COPD, etc. That you can call as mild category A with risk factors. So what is the treatment for them? For both the category A and mild and category A mild with risk factors, the test you need to do is do a COVID PCR test. That is very important. So any patient with fever, outpatient patient which is present, see not so severe symptoms, maintaining saturation, get a COVID RT-PCR done. Maybe if the COVID RT-PCR comes negative, or if they are complaining that they are having some difficulty in breathing, you can do a CT chest to see ground glassing opacities. Because many a times we have seen the RT-PCR coming negative, but the CT chest is very characteristic of COVID-19. And what is the management? Their management is symptomatic outpatient management. Don't need to do any specific treatment. You can just give them some multivitamins, zinc. Even that also has not been proven to definitely help, but just symptomatic treatment, some analgesics, some nasal decongestants, and maybe a simple paracetamol is sufficient for them. You can, if the patients are elderly, you may want to consider them that you may do a 6-minute walk test to see whether they are desaturating or not. So if you find that the patients are desaturating, or if their fever is not getting controlled, or their respiratory symptoms are slightly increasing, then what you can do is you can consider remdesivir. especially if patients are not vaccinated. Now, to have a patient who is having OPD like symptoms but not getting vaccinated is a bit less likely, because almost all of the people now has at least received one dose of vaccine. But if you suppose get a patient who is not vaccinated and who has OPD symptoms, then in these patients you can start remdesivir on OPD basis. Now this remdesivir will not be for a typical 5 days. This remdesivir will only be for a 3-day course. So this will be 200 milligram on day 1, then 100 milligram OD following for the next 2 days. Secondly, question arises, where do we place monoclonal antibody, that is casirivimab, indivimab. So casirivimab, indivimab can be given to these kind of an OPD patients who are not very sick, but we have to make sure that they are not having Omicron variant. So if you want to look at the RT-PCR test, if you look at the RT-PCR test, if there is no S gene dropout, then definitely you can see that if there is no S gene dropout, they are definitely not an Omicron variant. You can definitely consider monoclonal antibody in them. Or maybe if you have a report from a genomic testing and it is proven that it is not an Omicron variant, you can go for casirivimab, indivimab. But in today's era, what we are seeing now, that a lot of these patients are having S gene dropout, or even if they are not having S gene dropout, they belong to BA.2, 0.3, they definitely are an Omicron variant, and monoclonal antibodies will not work. So in monoclonal antibodies have a very limited role in, especially in the third wave and the fourth wave. Then the option is there about inhaled budesonide, which I'll come in the subsequent slides. And I will also talk about molnupiravir. Now, molnupiravir is also especially reserved only for those patients who are elderly, having comorbidities, and those who are not vaccinated. So that category is very less. So molnupiravir also now has not much of a role if you see in the algorithm for nowadays. So in a third wave, I would suggest the simple treatment is just a simple outpatient treatment, analgesics, paracetamol, nasal decongestants, maybe inhaled budesonide, but there is no role for monoclonal antibodies because it's an Omicron variant. And if at all a patient is not vaccinated, you may consider remdesivir in that particular cases. So if the patients are not improving over the next 7 days, then you will put them in category B, and then we will see what is the treatment. So just a few words about remdesivir. So this remdesivir in category A are for your unvaccinated, non-hypoxemic, high-risk patients. Administer a 3-day treatment for remdesivir as early as within 7 days of symptom onset. If they come beyond 7 days, again remdesivir has no particular role, because remdesivir is an antiviral and it rapidly decreases the viral load in the patients who are having COVID-19. So it has a high role in selected high risk or immunocompromised individuals may also benefit if vaccinated. The dose, as I told you earlier, is only 200 milligram day 1, then 100 milligram OD for next 2 days. Monoclonal antibody, yes, monoclonal antibody is basically only for those variants other than Omicron. Otherwise, if it's an Omicron variant, then the monoclonal antibody is relatively inactive. So you can consider in ambulatory patients more than 60 years of age with comorbidities. And again, a monoclonal antibody has to be started within 7 days, preferably within 72 hours of the positive test. Because if it is more than 7 days of the symptom onset, then actually monoclonal antibody is actually contraindicated, because the benefit can occur irrespective of the antibody serostatus. So what is this monoclonal antibody? I'll just have a few slides on this monoclonal antibodies. So these monoclonal antibodies are when they came into the picture, especially during the second wave, they were offering a promising therapeutic molecules which can be used for the prevention and treatment of infectious diseases. What is the mechanism of action? So if you see the monoclonal antibody, especially the casirivimab and indivimab, it's a novel combination of antibiotic. These two monoclonal antibody binds to the ACE2 receptor. Now this is the Omicron virus and this is the ACE2 receptor. As we can see, this indivimab and casirivimab binds to two separate regions of the ACE2 receptor of the Omicron virus. And this cocktail of two non-competing monoclonal antibody with different epitopes reduces the probability of viral escape. So then this virus cannot go and bind to the lung epithelial cells because these antibodies get binded to the ACE2 receptors. And this was the study which was published, which showed the efficacy of casirivimab plus indivimab. So it was a double-blind phase 3 randomized controlled trial for patients who had mild to moderate COVID. So they used two strengths of casirivimab and indivimab. They used casirivimab 600 plus indivimab 600 for almost 700 subjects, compared with the placebo of another 700 subjects. and they used a higher dose casirivimab, indivimab, that is 1200 milligrams each for patients amongst the group of around 1400 patients. And what they included is they included only those patients who had mild to moderate COVID, those who presented within 7 days of the RT-PCR result or within 7 days of the symptom onset. And if they were having severe disease, they were excluded from the trial. So what they found is basically almost 70% risk reduction was seen in hospitalization and all-cause death. So when they use a 600 by 600 strain, they found 70% relative risk reduction in all-cause deaths and in COVID-related hospitalization. When they used a higher dose, they found the relative risk was only decreased by 71%. So if you compare a low dose casirivimab, indivimab, or you compare a high dose casirivimab, indivimab, the difference is of just 1%. So if you ask me, definitely if you are going to use monoclonal antibodies for a non-Omicron variant, you can simply use a low dose monoclonal antibody, because a low dose monoclonal antibody is giving you 70% risk reduction, and giving a high dose is going to give you an additional only 1% advantage. So that is not significant. So that can be used, as I told you earlier. And of course, who are the category of people to be used? The high risk people, the people who are elderly, obesity, having these comorbidities. These are the people who needs to be used. And whom you cannot use COVID, these monoclonal antibody, are those people who are already hospitalized, those people who require oxygen, and those people who are already on oxygen and their oxygen concentration needs to be increased. In those people, monoclonal antibodies do not work. So where do we place monoclonal antibodies in our clinical armamentarium? So this you can see is the COVID therapy as per the clinical presentation. So no illness, healthy people we don't need to use. If there are asymptomatic people, then again there is no therapy we need to use. But if it's an early symptomatic people who are having presenting it to you within 7 days of symptom onset, mild clinical features, comorbidities which are present, and it is a non-Omicron variant, here is the role where casirivimab, indivimab can be used as a treatment. But when the person comes into the hospital admission stage, when they go into category B stage, then again monoclonal antibodies have no role. In fact, that is the time when you need to consider remdesivir or maybe even convalescent plasma. And when the patient requires hospitalized and is requiring oxygen, that is the time when you go into the steroids, role of steroids, dexamethasone, or basically immunomodulators like tocilizumab. So for a more sicker patients, you probably will go for dexamethasone plus tocilizumab, or probably baricitinib, which I'll come in the next few slides. So IDSA guidelines, these were the guidelines which came in 2021 during the second wave, and the IDSA guidelines suggested for high-risk patients, OPD patients, definitely monoclonal antibody was beneficial. Even your NIH guidelines had come up with this casirivimab, indivimab, or other monoclonal antibody which is not available in India, that is the bamlanivimab and estevizumab. So those antibodies we were proposed especially for their OPD patients. Drug-drug interaction. So COVID-19 vaccine can have a drug-drug interaction with monoclonal antibodies. So if you have someone who has taken monoclonal antibody and now they are due for vaccination, you may have to postpone their vaccine for at least 90 days after treatment of monoclonal antibody. So if you have given monoclonal antibody, after 3 months only you can give them the COVID vaccine. What about pregnancy? There is no contraindication to pregnancy. The monoclonal antibodies can be given in pregnant patients as well. Even for breastfeeding considerations, monoclonal antibodies can be given to mother even if they are breastfeeding. The safety profile, it is quite relatively safe. The only side effect what has been seen is basically infusion related reaction. For example, they can have certain fever, chills, some headache that can be seen. In these cases, actually the casirivimab, indivimab should be given over a period of 1 hour as an prolonged infusion. What is the difference between monoclonal antibody and convalescent plasma? Convalescent plasma is derived from recovering patient and is to be used only for hospitalized patient and not to be used for outpatients. In contrast, monoclonal antibody is not indicated in hospitalized patients. So if you have a OPD patient, you can go for monoclonal antibody. But if you have a hospitalized patient, in those patients, you may have to go for convalescent plasma because monoclonal antibody is not indicated for them. So in summary, this is basically from the second wave. India was seeing a surge in COVID-19 cases, and this monoclonal antibody had a good action against the target receptor and binding domain of the spike protein, and it helped in reducing the viral replication. The cocktail was effective against these variants, and it reduced the chances of viral escape. But if you ask me, in today's day and age, when we are seeing Omicron variant, probably monoclonal antibodies have no use at present. So what are the take-home points from monoclonal antibodies? Therapies are available for treatment of mild to moderate COVID-19 in outpatient setting, and there is growing evidence which says that monoclonal antibodies are beneficial. But if you have to look at the variants and then decide on the monoclonal antibodies. Then I told you a few things about inhaled budesonide. So again, for the outpatient patients, you can use for inhaled budesonide. Again, you have to start it within 6 days of symptoms, and the dose is typically 800 micrograms twice daily for 7 to 14 days. So typically your dosage for budesonide for bronchial asthma is usually 400 micrograms, but for your COVID outpatient patients, you can use budesonide for up to 800 micrograms. Molnupiravir. So when Molnupiravir came into the picture, there was a lot of hope that this is probably the antiviral what we are looking for, especially because Molnupiravir was in the oral form, it was a tablet form. But later on, studies have shown that Molnupiravir is probably not that efficacious, and Molnupiravir is especially indicated only for an unvaccinated or COVID IgG negative patients. The dosage was 4 tablets of 200 milligrams, that is 800 milligrams twice daily for 5 days, and it has to be started within 5 days of symptom onset. And you have to avoid in pregnancy because this Molnupiravir could be having teratogenic effect. So Molnupiravir initially had shown a lot of promise, but later on it came to our notice that Molnupiravir probably is not that beneficial, and if at all it has any role, it has only role in unvaccinated people, elderly people with comorbidities, but you have to give it with a pinch of salt. Then comes after the category A. The category A, we saw the OPD patients and what is the management. Then comes the category B. The category B patients are patients who require respiratory rate more than 24 per minute and whose oxygen saturation varies between 90 to 93%. In these patients, you admit the patient in the ward because they require hospitalization, and you have to do these tests like CBC, chest X-ray, D-dimer, procalcitonin, and all those things. And these are the patients become slightly hypoxic because they require oxygen, but they don't require oxygen more than 8 liters per minute. But because they require oxygen, they are hypoxic. You need to start these patients on dexamethasone. And also you have to start them on prophylactic anticoagulation. You can encourage self-proning. High dose monoclonal antibody, if it is not an Omicron variant, that is the high dose monoclonal antibody up to 1200 plus 1200 may be beneficial for these patients, but we require more data to support it. So you can try monoclonal antibody for this group of patients, but in general, when we say hospitalized patients, we avoid monoclonal antibodies. And of course, if the patient comes to you with category B within first 7 days, you can give remdesivir in these particular patients. So remdesivir in category B patients is a 5-day course. So unlike what we saw remdesivir in category A OPD patients, which was only a 3-day course, remdesivir in category B patients is usually a 5-day course, and it has to be given in patients who come within 7 days of onset and who are in low flow oxygen. If they require high flow oxygen, again remdesivir does not give any benefit. Again, there is a study which showed that probably remdesivir offers no benefit in patients who are already steroid treated, because by the time they have steroid treated, their viral load has come down, and it is more an inflammation which is causing complications. So for inflammation, decreasing the inflammation, you need dexamethasone and you don't need remdesivir. So remdesivir is only basically for the first 7 days if the patient comes into it. Remdesivir may reduce the duration of hospital stay and improve oxygenation in patients, especially those who require low flow oxygen or low flow mechanical ventilation. And co-administration with HCQS should be avoided. In fact, HCQ we don't use nowadays. I'll show you one trial which showed that HCQ is not useful. So HCQ is not used nowadays. And if you're using remdesivir, definitely don't use HCQ because they have significant interaction, and monitor the LFT. The monoclonal antibody for category B, yes, again, if it's not an Omicron variant, you may consider monoclonal antibody, but this time you have to consider a high dose monoclonal antibody, that is 1200 by 1200. by in this particular patients. It is again limited to patients who come to you who are not in going in severe hospital, severe oxygenation requirement, and who present to you early within the first 7 days. So if they come to you within the first 7 days and they are in category B, and if they are non-Omicron variant, then you may want to consider giving monoclonal antibody at a higher dose. But how much benefit does it actually give is debatable. And finally, the definitive treatment for patients who are hospitalized and those who require oxygen is basically a dexamethasone, which is 8 milligram once daily for 7 to 10 days. Increase the dose to up to 16 milligram if people require oxygen for more than 10 liters per minute. Alternatives is that you can use hydrocortisone 50 milligram Q8 hourly, or you can use methylprednisone 32 milligrams per day. In hypoxic patients who cannot be admitted due to bed availability, you can consider oral dexamethasone. So this was another problem which we saw during the second wave. When patients were hypoxemic, they needed oxygen, they needed dexamethasone IV, but we could not give them. So they can take home oxygen, and along with home oxygen, they could take oral dexamethasone. So that time we had prescribed them oral dexamethasone as an outpatient treatment. Always give ivermectin 1200 microgram, that is 12 milligram of ivermectin, because when we give dexamethasone and if the patient is having strongyloids, they may go into strongyloids hyperinfection, which is a very high mortality rate. So all patients who are going on dexamethasone should receive at least a single dose of ivermectin. Then anticoagulation, definitely for category B patient, you should go for prophylactic anticoagulation with low molecular weight heparin. The dose of enoxaspirin, as we all know, is 40 milligram, which needs to be given subcutaneous OD. Contraindication, if there is any active bleeding or platelet count is low. And start therapeutic anticoagulation, especially in the patients who are going into category C, or if they have very high D dimers, which is almost 4 times normal. Then instead of giving prophylactic anticoagulation, you may have to give them therapeutic anticoagulation. Moreover, at the time of discharge, you can switch the patient to an oral anticoagulation like probably rivaroxaban or its equivalent for 2 to 4 weeks. Then we saw category B. Now comes category C. Now category C are your sickest patients. So these are the patients who need to be admitted in COVID ICU. These are the patients who may have cardiac complication. You may want to do an anti-pro-BNP. These are the patients who require dexamethasone, maybe 8 milligram or probably 16 milligram. You may need to start them on prophylactic anticoagulation, but maybe you need to go to a therapeutic dose as well. And of course, these are the patients who need to be started on tocilizumab or baricitinib. And these are the patients probably will have secondary infection as well. So you may need to consider giving them antibiotics as well. What about tocilizumab? So there was some debate whether tocilizumab is helpful or not. But as per the last conclusion of the various studies, it showed that administration of single dose within 24 hours of worsening of patients whose FiO2 requirement is more than 0.4 or whose high flow nasal oxygen rate is more than 30 liters, they would be benefited with tocilizumab. The dose is a single dose infusion, 8 milligram per kg, not to exceed more than 800 milligram. And of course, we have to avoid tocilizumab if we are suspecting infection, because there could be secondary complication which can occur as well. What about baricitinib? Yes, now baricitinib is a better drug than tocilizumab, especially on patients who are requiring oxygen. So patients who cannot receive tocilizumab or you don't want to give tocilizumab, you can give this baricitinib. It is basically for patients who require again high flow oxygen more than 8 liters per minute, and the patients who are not improving with standard dexamethasone. So you can give this tablet baricitinib. The dose is again 4 milligram orally through the NG tube for 14 days or until hospital discharge. Again, you have to modify the dose if there is a kidney dysfunction which is present. Then just a few infection control preventive measures. So we saw the category A, category B, category C treatment. Along with this, you have to make sure you have a good infection control, because we don't want secondary infection to be occurring. So definitely you have to do home quarantine for those staff who have been exposed. All those patients who have been there have to be put into a respiratory isolation unit, and the staff which have been exposed needs to be quarantined. So let us have a look at some of the investigational therapies. Now, if you look at investigational therapies, there was a lot of hue and cry regarding the use of chloroquine, hydroxychloroquine, and azithromycin. But the ultimate conclusion is that chloroquine, HCQS, and azithromycin, it does not work. Why it does not work? Because if you compare chloroquine, the high dose chloroquine versus low dose chloroquine, this was a randomized double-blind controlled trial in which there were severe COVID-19 patients. And in fact, the study was stopped because of the data safety issues. And if you look into the overall fatality, the mortality was higher in the high dose arm compared with the low dose arm. So definitely giving high dose chloroquine was causing more fatality as compared to not giving it at all. So the interpretation was that despite a small number of patients enrolled, the study raised serious concern of increased mortality with high dose chloroquine. So if you give high dose chloroquine, it had more mortality. So the study was stopped and the recommendation was against giving high dose chloroquine. What about hydroxychloroquine? Now again, they compared hydroxychloroquine with the standard of care. This was a multi-system randomized control trial. They compared hydroxychloroquine with the standard of care, and they found that no difference was found between the HCQS arm and the standard of care arm. There was no difference in time to negative PCR conversion, and there was no difference in the rate of symptom alleviation as well. Moreover, in the hydroxychloroquine arm, adverse effects occurred more than 30% of the participation. So this study again demonstrated there is no difference in viral clearance between hydroxychloroquine and the standard of care. So your chloroquine is out, your hydroxychloroquine is out. What about hydroxychloroquine plus azithromycin? Now, this was again another trial which compared hydroxychloroquine with azithromycin versus no azithromycin. And again, they found that there was no difference which was observed in the risk of mechanical ventilation. The risk of death or any cause was higher in the hydroxychloroquine group. So actually it is causing more harm than good. So ultimately, this study showed no beneficial effect of hydroxychloroquine plus azithromycin for the treatment of COVID-19 and a possibility of association of hydroxychloroquine associated increased mortality. So again, SCQS plus azithromycin, that is also out. This is another study which showed HCQS with azithromycin. It showed it can prolong the QTC interval and it can cause cardiac complication. So definitely HCQS with azithromycin should not be warranted. And finally, this was basically the recommendation which I presented coming to the Lancet. And they said basically that each of these regimen was associated with decreased in-hospital survival and increased frequency of ventricular arrhythmias. So with this paper, I think so hydroxychloroquine and chloroquine with a macrolide, that is azithromycin, was totally banned and it is no longer used. This is the solidarity arm which the WHO itself had done with the HCQS where they were used. So in this solidarity trial, the HCQS arm had more mortality which was associated. Hence the HCQS arm was stopped in this solidarity trial by the WHO. So the ultimate recommendations by the NIH was there is insufficient clinical data to recommend either use of chloroquine or hydroxychloroquine for the treatment of COVID-19. The COVID-19 treatment guideline panel recommends against the use of chloroquine. The combination of hydroxychloroquine and azithromycin is associated with prolonged QTC interval, and the panel recommends against the use of hydroxychloroquine plus azithromycin. So I think this was the final nail in the coffin for chloroquine, hydroxychloroquine, and azithromycin, and we don't have to use those molecules anymore. Then the second investigational therapy was regarding the lopinavir-ritonavir. Now, lopinavir-ritonavir also does not work, as I can show you in this study, where they compared lopinavir-ritonavir with the standard of care. What they found, there was a lower, but it was not a statistical significant mortality rate in the lopinavir-ritonavir arm. There was slightly shorter stay for those in the lopinavir ICU arm, but the duration of hospital stay was same in both the groups. In fact, the time to clearance of viral RNA was also no different. And there was nausea, vomiting, and diarrhea. All these were more common in the lopinavir-ritonavir arm. So what they ultimately interpreted is that this moderate size randomized control trial failed to find any virological or clinical benefit with lopinavir-ritonavir over the standard of care. So again, lopinavir-ritonavir initially showed a lot of promise, but ultimately it showed no significant improvement as compared to the standard of care. So what is the final recommendation by the NIH? The panel recommends against the use of lopinavir-ritonavir or any other HIV protease inhibitors for the treatment of COVID-19. Then there are other immune-based therapies. So these therapies, again, the data is very minimal regarding the data. There is insufficient data to recommend either the use of convalescent plasma or SARS-CoV-2 immunoglobulins, which is present. Then there is this study about, there are these experimental molecules like anakinra, interleukin 6 inhibitors. Again, the NIH recommendation suggested there is insufficient data against the use of these interleukin 1 or interleukin 6 inhibitors. And except in the context of a clinical trial, the panel recommends against the use of interferons or basically any other molecules. So based on these arguments, as like I told you, there is no single treatment which has been proven to be effective. More data and data studies needs to be elucidated. The only thing that I can say basically works is basically if you have is basically in the early part of illness, if you have the infection that is within the first 7 days, preferably within the first 72 hours. And if it is not an Omicron variant, monoclonal antibody can be beneficial. If it is an Omicron variant, again, monoclonal antibodies are not beneficial. But in those cases, remdesivir has been shown to decrease the viral clearance, and it is known to show beneficial in respect to fever. So remdesivir can be used in the initial part of illness, but again within the first 7 days. Beyond 7 days and hypoxemic patients, the only drug which is shown to be beneficial is basically a dexamethasone. So monoclonal antibody, remdesivir, and dexamethasone. These are the only three agents which I would say has some role in the COVID-19 in the present era. Then few infection control measures like follow the culture of namaste, practice hand hygiene, avoid close contact, always wear a respiratory, all wear a mask, especially a N95 mask or a 3-ply mask, follow respiratory hygiene or cough etiquette. Respiratory hygiene, this I don't need to stress, we need to do the hand hygiene and we need to use the proper respiratory and cough etiquette. And of course, for those people who are getting in contact with the COVID-19 patient, you should need a wearing a PPE. Now, as we are seeing more and more studies and more cases of Omicron, we are seeing that PPE also does not need to be a full PPE. Just a simple mask, gloves, and gown is sufficient in coaching this PPE. You don't need a entire PPE from head to toe covering, which is needed. And of course, hand sanitizer is very important. You need to do that. So once we have seen that what is the COVID-19 clinical features, what is the COVID-19 management, let us have a few words about the COVID vaccine. Dr. Gunadhar, do we have time or should we wind up the session?
No, we can continue.
Okay. So I will show you about the COVID vaccine. So two vaccines have been approved in India. One is the Covishield and one is the Covaxin. And these are of course, the Sputnik vaccine also has been come into the market, but not at every place. But I'll discuss mainly these two vaccines. So this is the Covishield vaccine. So Covishield vaccine is basically a viral vector vaccine. It uses a non-replicating strain of a chimpanzee cold virus, that is basically an adenovirus, to carry the genetic material of the spike protein or SARS-CoV-2 into the human cells. So it was a viral vector vaccine which was carrying an adenovirus along with the SARS-CoV virus, whereas Covaxin is basically a typical vaccine what we always know, that is an inactivated strain of the virus. So it carried an inactivated SARS-CoV virus which is disabled for replication. However, the proteins are intact which are able to provoke immunity to the host. These are the constituents of the Covishield and the Covaxin. I will not go into the details. Both the vaccines can be stored at 2 to 8 degrees, making it very convenient to store and transport. What is the mechanism of immunization? The Covishield vaccine produces antibody only a specific region of the virus, whereas Covaxin has an advantage that it can produce antibody against many other regions of the virus because it's a more complete virus. For the Covishield, it contains a portion of DNA that codes for the spike protein, that is the S protein. So it is typically against the antibodies against your S protein. So once inside the cells, the DNA part first needs to enter the nucleus to create its mirror image, that it forms a complementary RNA. Then this RNA comes out of the cytoplasm as a messenger and starts making S protein through a machine available for this process called as the ribosome. So since it's the S protein that provokes immunity, it may not be close to natural immunity as Covaxin. So Covishield is more specific to your S protein of the part of the COVID virus vaccine. But advantage of Covaxin is the Covaxin is actually an inactivated COVID virus. So since the vaccine contains a full inactivated virus with all its 29 proteins intact, the immunity provoked by it will be more comprehensive and closer to natural immunity. So in that way, if you see, Covaxin is probably a better vaccine because it covers other regions of the virus as well, whereas Covishield mainly covers only basically your S protein. If there are any long-term side effects because of the DNA material, we do not know about the Covishield vaccine. But so far, DNA vaccines were only being tried for cancer patients and never being used for human subjects. But whereas the Covaxin is a time and tested technology which we are using for other vaccines like polio vaccine as well. However, these vaccines require an adjuvant. For this purpose, alum is commonly added to evoke the type 2 receptor cell immunity. So instead of the so what the Bharat Biotech has used is they have added this imidazoquidolone, which stimulates the type 1 immunity, which is also generated by other mRNA and DNA virus vaccines. So if you see, Covishield is more specific, Covaxin is more broader, but each one has its own advantages and disadvantages. Covishield, as I told you, it is manufactured by AstraZeneca by the Oxford University, and it has completed its trial in various countries. Whereas the Covaxin was mainly developed by Bharat Biotech in Hyderabad in India, and its phase 1 and phase 2 trials were mainly involved subjects basically in India. The regimen, 2 doses needs to be taken. The 2 doses has to be given at a gap of at least 3 months. Covaxin, 2 doses needs to be taken, but there can be only a 4 weeks gap, which is sufficient. What about efficacy? Now, if you look at the efficacy, the Covishield has an average efficacy of more than 70% when 2 doses are given. But if you increase the gap between the 2 doses, for example, if you make the gap instead of 4 weeks, you make the gap of 12 weeks, the efficacy increases from 70% to it increases to 82.4%. Whereas about the Covaxin, if you look into it, Covaxin has an efficacy rate of around 81%. But again, thus from an efficacy point of angle, Covaxin scores over Covishield because it is having a more efficacy data and more robust data, especially involving the Indian subjects. What about protect against the mutations? We do not know specifically whether these Omicron variants are going to be protected by the Covishield and the Covaxin or not, because we need more studies up to it. There are some studies which show that probably there is a virological escape by the Omicron variant against these vaccines, but still I would suggest you need to take the vaccines so that at least some of the variants are covered. What about the side effects? Both Covishield and Covaxin have certain side effects. For example, anaphylaxis, stiffness in the arm, joint and muscle pain, maybe some enlarged lymph nodes. Those things can be present with Covishield as well as with Covaxin. Price, as I told you, now it is available. Government is giving free, and even in private hospitals, you are getting at a reasonable price rate. So the question always I get is basically, which vaccine should you prefer? Should you go for Covaxin or should you go for Covishield? Now, both the vaccines are very good. So I have just made some points. When would you prefer Covaxin over Covishield? That is, if you see, the higher efficacy of Covaxin comes out of robust data from one double-blind controlled clinical trial as compared to lower efficacy of Covishield with results pulled from multiple trials. So if you look at the efficacy wise, Covaxin is better. Covaxin also seems to have a distinct safety advantage with the lack of anaphylaxis and potential for neurological adverse effects as compared with Covishield. And only 2 cases of transverse myelitis was associated with Covishield, but not with Covaxin. So if you look into the efficacy wise and you look into the adverse drug effects, Covaxin definitely has an advantage over Covishield. But when do we suggest Covishield more than Covaxin? If you see Covishield seems to have advantage over Covaxin being approved in many European countries and Australia, where Covaxin is only approved in India and Zimbabwe. So if you look into the trials, Covishield has been tried much more compared to Covaxin, especially in the other European countries and Australia as well. And so by now, millions of doses of Covishield has been given. So if you look into by sheer numbers, Covishield vaccine has been given in many more patients, and its safety has been noted in many of the cases. So Covishield may therefore be a natural choice for those who value external endorsement. So if you want to go in terms of numbers and see the safety in terms of numbers, Covishield is definitely better than Covaxin. But as I told you, it's an individual choice whether you want to go for Covaxin or you want to go for a Covishield. And lastly, I will come to the few post-COVID complications. So these post-COVID complications are the things which we see more nowadays. We are not seeing so much of acute cases. At least we are seeing only acute cases for the last 2 to 3 weeks. But prior to that, we had seen a lot of post-COVID cases, and these post-COVID complications, what we called as long COVID syndrome or long hauler syndrome. So these are the symptoms which persisted beyond 3 weeks from the COVID onset. And there's another terminology called as chronic COVID syndrome. Now, these were the symptoms which were extending beyond 12 weeks from the symptom onset. So long COVID syndrome were the patients who had COVID, and up to 3 weeks after the COVID syndrome, they still had certain symptoms. Those we were calling them as long haulers. And what was the pathophysiology? They seemed to have some permanent organ damage from the acute infection and the ongoing inflammation which is present. What is the frequency? Usually it is mild disease. Up to 35% adult patients with positive COVID test come with these symptoms. And in some cases, it can go into moderate to severe disease where patients may require hospitalization. So the long COVID syndrome, what are the common symptoms they present with? They present with fever, which may prolong for beyond 2 weeks. They may have fatigue, they may have dyspnea, they may have cough, they may have joint pains, they may have chest pain, and sometimes there is this criminology called a brain fog. They may have cognitive dysfunction. They don't seem to be of their usual persona. They can have memory impairment, which is present. So these brain fog like symptoms are also seen. And of course, these all symptoms occur at various frequency. As you can see, during acute COVID syndrome, also fatigue is there. Post-COVID syndrome, also fatigue and dyspnea, and these all symptoms can occur. What is the treatment? Well, if they are having dyspnea and they require oxygenation, you need to give them oxygenation. Maybe you can get done a 6-minute walk test or a PFT done to see their baseline saturations. You need to probably give an inhaler like a beta agonist inhalers, which needs to be given. Antifibrotics, whether they are really useful, we do not know unless and until it is documented to have lung fibrosis post-COVID treatment. And of course, there is more of supportive and psychological treatment needs to be given for them. Another post-COVID symptom which we had seen, especially during the second wave, was the mucormycosis. Now, this mucormycosis is caused by the fungi of the order of mucorales, and the most common species are the Rhizopus, Rhizomucor, Cunninghamella, Saxinia, Absidia, so on and so forth. This is a typical picture of a mucor species, and it is affected either to ingestion, inhalation, and traumatic inoculation. Most common it is through inhalation. So different types of mucormycosis has been noted, but the most common type of mucormycosis are the rhinocerebral orbital. It is the ROCM, which is most common. Of course, pulmonary mucormycosis, GI mucormycosis, cutaneous mucormycosis are also known to occur. But the most common is the rhino-orbital cerebral mucormycosis. And patients who had COVID, along with that, if they had diabetes, they were the most highest risk factors for developing the mucormycosis, whereas these other risk factors were also known to occur. So rhinocerebral mucormycosis, more than 50% of the cases were with diabetes. They were, especially they had high sugars, and many of them had diabetic ketoacidosis. As we know, that is a place when there is diabetic ketoacidosis, that increased chelation of iron is present, and there is acidic environment that further enhances the growth of mucormycosis. Clinical features: they present with nasal stuffiness, facial pain. They may have proptosis, ophthalmoplegia. And of course, they have a very typical eschar. If you look into their nasal turbinates or palate, they have very classical nasal eschar. As I'll show you over here, this is the nasal eschar, which is typically seen. This is the MRI findings. As you can see, this is the mucormycosis, which has invaded into the nasal mucosa. And this is a clinical picture, as you can see, involving the orbit, which is present. And there can be complications like cavernous sinus thrombosis, visual loss, frontal-lobal abscess, so on and so forth. The diagnosis definitely by taking a biopsy, either the fungal culture is positive or the histopathology shows a typical aseptate, broad branching, broad hyphae. This is an example of a GI mucormycosis. As you can see, this black color present in the autopsy specimen. Treatment definitely involves surgical debridement. You should definitely do surgical debridement because the burden of the fungal infection should decrease. And of course, along with that, you need to give the liposomal amphotericin B. The dose will be around 5 milligram per kg body weight. If you cannot afford liposomal amphotericin B, then probably you can go for isovoconazole, or in that case, we can also use posaconazole. So remember, regarding this post-COVID syndrome can occur in any patient without symptoms during the acute stage. Fatigue is the most common symptom. Post-traumatic stress disorder is a common occurrence which you see, especially after ICU admission. Regular follow-up is mandatory for the patient. And of course, consider venous embolism prophylaxis for patients who are at high risk for embolism. So I'd like to conclude by saying there is no reason to panic, but there is every reason to take precautions, especially in your COVID-19. And probably we are seeing in the beginning of an early fourth wave, but we don't need to worry because it's mainly a category A type of patients which are there. So it's probably we are not expecting so many complications which may occur. With that, I'd like to conclude the presentation. Thank you very much.
Yeah, thank you, Dr. Lakshman. I think it's a wonderful presentation, and I think you have covered most of the part of this COVID for our exam goers. So there are one or two questions. First, I would like to ask you from in the chat box. One question is by Dr. Narendra. So, what is the treatment of choice of COVID in pregnancy? Is remdesivir is safe? So, what is your take on this?
Pregnant patients with COVID-19.
Yes, yes.
Yes, yes, remdesivir is safe. You can definitely use remdesivir because the benefit of remdesivir is much higher than the damage which remdesivir causes to the fetus. So there have been very few studies which have shown that the remdesivir can be harmful. So remdesivir is definitely safe in pregnant ladies. If the patient is pregnant, there is higher chance of going into complication. So it's better to give remdesivir rather than avoiding it.
Okay, thank you. Okay, now there are one or two questions I'll just like to ask to other panelists like Dr. Charu. So the thing is that what is the your treatment of choice in severe COVID, like dexamethasone or versus methylprednisolone? Because many of the centers, they are using methylprednisolone over dexamethasone. So what is your protocol in your center?
First of all, thanks Gunadhar for having us here.
Again, I think your audio, you are muted. Yeah. Some technical issue. Yeah.
Can you hear me now?
Yeah, yeah.
So I wanted to thank you for having us here, and Dr. Lakshman, a great presentation, a superb overview of what has happened over the last 2 years. I'll say in our institute, we were using methylpred as our steroid of choice. Why? Because we started using steroids in the beginning of the pandemic, even before the recovery trial was out, and that basically got stuck with us. No particular reason apart from that, and it was just in the protocol of how we were treating patients, and that's basically the reason. And as Dr. Lakshman rightly sort of summarized at the end, the treatment options are extremely limited in terms of the medicines. But one or two points which I wanted to make is that for moderate to severe COVID, I think it's important that we follow the standard ICU practices in these group of patients, because more than the medicines, it is what we do in the critical care which is important. Basic things like timely use of high flow nasal cannulas, awake proning, which has shown good benefit in these group of patients, intubating patients on time, then prone ventilation in appropriate group of patients. I believe these things do make a difference in the outcome, and more so than what the medicines would do. I mean, that will be my take on this.
Yeah. And the duration of the methylprednisolone is for how long you continue steroid? For 5 days or for 10 days? Or how do you taper it basically?
So we follow the CRP as our marker of inflammation, and we did not like to give it as a prolonged course. By and large, on an average, we had people on would start like 40 milligrams twice a day as a general dose, and then after 3 days, if there is an improvement in the CRP and clinical improvement, then we would start tapering. We would not go beyond 5 days for sure. And if people are having still rise in the CRP, we would be suspicious that there may be a secondary infection brewing, and we'll look at those parameters rather than bombarding them with ongoing steroids. And we would be tapering them after 3 days most of the times, 5 days tops, and then look at other reasons for why the inflammation or the infection is not settling down.
Okay. And to Dr. Diptes and Dr. Ketan, so the regimen for the thromboprophylaxis or the treatment of thrombosis during the COVID storm.
Okay, so thank you, Dr. Gunadhar, for giving us an opportunity to on this platform. And Dr. Lakshman has very well described the COVID treatment and initial course and what is the current line of management. Coming to the question of prophylaxis, so we divide these patients into two categories. Number one is mild, whether the patient is hospitalized or non-hospitalized, and in hospitalized patient, mild, moderate, and severe category. Especially patients who have high risk of VTE or have a proven VTE, we will use therapeutic anticoagulation. Otherwise, patients who are on oxygen therapy in ICU, we will use prophylactic anticoagulation. That is our strategy for COVID-19 thromboprophylaxis.
So do you monitor for D-dimer or only if you monitor means give the
Number one is we do a baseline D-dimer when on admission. And if the patient is in cytokine storm, naturally the D-dimers are quite elevated. So we try to correlate clinically, and a D-dimer level of more than 1,000, depending on what units you are measuring in your lab. So if a significant level is there, we will put the we will titrate the anticoagulation and plus clinical profile of the patient. But having said that, as per the studies, D-dimer has not been shown to correlate clinically with the risk of thrombosis in COVID. So we go more of depending on the risk category and any proven evidence of thrombosis like DVT or PE.
Okay, what about your view, Dr. Diptes?
Yeah, thank you so much. Really comprehensive and excellent presentation. Regarding the DVT prophylaxis, I'd like to share our experience from Nepal. So the prophylactic anticoagulation has been the standard of care, and we also participated in the REMAP-CAP clinical trials, which one of the domains was whether the therapeutic anticoagulation was helpful in COVID patients. So that was published. It was a multi-platform randomized controlled trial, was published in New England. And what it has shown that in moderately ill patients, the therapeutic anticoagulation did have a benefit in terms of organ-free support, organ support-free days. But surprisingly, in severely ill and critically ill COVID patients who required some kind of life support, the therapeutic anticoagulation didn't help. In fact, it was more harmful. So since then, since that trial included patient population from our part of the world as well. So in most of the ICUs in Nepal, the standard practice is to give therapeutic anticoagulation in moderately ill patients, prophylactic anticoagulation in all the patients, but we do not use therapeutic anticoagulation in severely ill patients. So that has been a practice in most of the ICUs here. Thank you.
Yeah. Wow. Actually, those patients who are at high risk and D-dimer levels are elevated from the baseline. The prophylaxis may be required in those high risk patients, especially cancer patients or patients who are probably having very high D-dimer values and high risk of thromboembolic episodes. I think thromboprophylaxis can be continued for 4 weeks and then later on, depending upon the risk and it can be tapered. But those who have already developed thromboembolic episodes like pulmonary embolism or stroke or pulmonary infarcts, probably these are the patients who will need longer duration of the prophylaxis with anticoagulation. My question to all the panelists is one more, like, we have been using antibody cocktail for quite a long time, and we have seen that casirivimab and imdevimab combination has been quite useful, and it has been seen in some studies and data also. It is not found to be useful for Omicron virus. So, but the newer preparations like sotorivimab is also available. Any center has having any experience of using sotorivimab for Omicron affected individuals who come early within 72 hours, and anybody has used these antibody cocktail regimens? And what about the recent the studies that have shown that we started early? How early do you start as casirivimab, imdevimab combination is concerned? 3 days, 4 days, or 72 hours? And what is the protocol? your. So starting with Dr. Ketan, Dr. Deepesh, and Dr. Lakshman, like to give you some. Okay, can you give us some insight? And from Dr.
Uh,
Charudat also. Is your
so, Dr. Kilesh, about cocktail antibody, we have quite widely used it. Now, indication to use it, of course, a patient who is not on oxygen therapy, and most of the time we have used in first 5 days, 5 to 6 days of illness, and these group of patients are mainly who are admitted in the wards. We have used quite early. Some of the patients we have also used on a OPD basis. We have given this cocktail antibody, and it has shown a quite significant recovery in some of the patient in reducing the symptoms. So this is our cocktail antibody experience. To tell you anecdotally, we have also used in patients, though FDA is not approved, but some of the patient which has a low oxygen requirement, very low. So those patients who had a positive 6 minutes walk test, those patients have shown remarkable recovery while using a cocktail antibody. While we don't have any other we have absolutely not used in a patient who are mechanically ventilated or a critically ill patients in ICU or moderate or severe category. About the second antibody, we haven't used in our centers, so we have no much experience about that.
Dr. Deepesh? Dr. Deepesh, what is
Yeah,
your
so
experience?
unfortunately, like those medicines are not available in Nepal, so we don't have any experience of using those kind of antibodies here. We just prescribe steroids. Sometimes like tocilizumab had been used earlier, but it's very expensive, and it's not like a regular standard of care. So we just use steroid, remdesivir. Yeah, that's it.
Dr. Charudat and Dr. Lakshmi?
So, I mean, we use the MAP therapies, the cocktails before the Omicron. But I mean, Dr. Lakshman can also add to this because of the lack of the spike gene, the efficacy of the casirivimab and the Regeneron antibody cocktail is not that effective, is what the evidence is. So we initially, when the cases were up, we used it in few patients, but then we stopped using it. And there is enough evidence to say the remdesivir short course, 3 days course, is sort of equally effective to the MAP therapies. And if you use early, so one of your questions was how early. So it is as early as you can, because it is, you're using it as an antiviral therapy, um, so that before the virus attacks the lung cells and cause the inflammatory reaction, is what you want to catch the virus with these things. So we are not using the antibody cocktails with the Omicron surge now in the third wave, and we're limiting ourselves to remdesivir, and that too for high risk category patients.
Yeah, I agree with Dr. Charudat what he said. So we had used extensively monoclonal antibodies during the second wave, and there were two ways in which we used. One was for your OPD patients who presented within 7 days of symptom onset, preferably within the first 3 days, and they were not non-Omicron variants. We used them, and we used them at a low dose therapy. The second category we also used for some of the hospitalized patients who were on very low oxygen or no oxygen at all. And in those, we used high dose therapy. But because of want of the cost, because the cost of double dose is even higher, in many of these patients, we used low dose casirivimab, endemic in hospitalized patients as well. But in the current third wave and possibly now the fourth wave, we are not using this monoclonal antibodies.
So in various countries where the remdesivir is probably not available, and some of the hospitals, even the smaller hospitals, they have used cocktail regime like ivermectin along with hydroxychloroquine. And still, in on OPD basis, people have written this cocktail regime, which was published in Australian New Zealand journal, and they have a lot of advantages that was shown in their study. So what is your say on this? I mean, should we use it, keep using it or not? Like it is a poor man's therapy if it is considered for COVID treatment. So would you still recommend this regime if none of your other therapies are available? Like, remdesivir is also not available, and you have other, antivirals which are not available in your center. Yes, molnupiravir is also now recently available. So, what is your take on that as well, as far as molnupiravir is concerned? And if that is also not available, would you still recommend using ivermectin with hydroxychloroquine and vitamin C as a combination for COVID-19?
Is the question directed to me, Dr. Akhilesh?
Yeah, yeah, yeah.
Yeah, so I am strictly against this ivermectin, hydroxychloroquine, chloroquine, azithromycin. I'm strictly against because there is no data, robust data, which is available to show it is of any definitive beneficial value. In fact, remdesivir itself is many data shows that even remdesivir is of questionable value. But the only drugs which are shown to be beneficial somewhat is remdesivir, dexamethasone, and your anticoagulation. These are the only three things. So I am totally against this cocktail of ivermectin plus vitamin C plus chloroquine because they cause more harm than good. So I would suggest even in places where you do not have access to remdesivir, just symptomatic management is sufficient. And if the patient is hypoxic, then go for steroids. This much treatment is sufficient.
Yeah. So basically, Dr. Ditya's has put an article which is in the Lancet publication, recent Lancet publication on respiratory medicine. So it has shown that the baricitinib has better profile compared to the dexamethasone when used along with remdesivir. So how is your take, Dr. Charu and Dr. Lakshman or Dr. Ketan? Dr. Charu?
Um, I mean, honestly, we have not used this agent at all in our place. I mean, even the tocilizumab, we have not used it after the first wave. I think we were one of the first centers to try tocilizumab in the beginning. But what we soon realized is that the secondary infection rate is terrible, and I mean that fear. I mean, I believe that there are certain category of patients who do benefit with these agents, but how to identify them? And then what we observed is that these patients who receive these agents, they would uh, get better from the COVID lungs, but then they succumb to secondary sepsis, terrible sepsis. And I mean, this has been our problem. I don't know what the other experience is, but we've been extremely scared of using these agents. And as Dr. Lakshman had summarized, we stick to just remdesivir and steroids, and that too, in a limited space. Because of this worry of secondary infection, we've had plenty of patients who just died because of sepsis rather than COVID in severe cases. So
Yeah.
I think we will not use this agent at all.
Yeah. So I'll just like to add one thing because I think your center has done one trial in Sepsivac, the newer one of the newer therapies.
Yeah.
So what is your take?
So thymosin, because we used it on the grounds that it's an immunomodulating agent which has it stimulates the CD4 CD8. So rather than being immunosuppressive, it is immunostimulant. I mean, we used it. It was not an RCT or anything. We did see the patients who we used have successful outcome. I mean, it was a positive study from an observation point of view, but it is not an RCT. So I'll take the result with a pinch of salt. And as I said before, I think the basic ICU care is very, very important. And purely as it was not an immunosuppressive therapy, we use that instead of tocilizumab or baricitinib.
So
So,
Any
so
experience of using interferon in COVID-19 infection? Yeah, Dr. Charudat.
Sorry, Akhilesh, I didn't hear the question.
Yeah, I said, I mean, any experience of using interferon for COVID-19 infection? Anybody is used?
No, no. I mean, the only extra agent we used was this thymosin alpha. As I said, it's a CD8, CD4 stimulant. And no other agent we have used apart from the steroids, of course.
Dr. Ketan, Dr.
so we have used interferon beta 2, and it was coming in a subcutaneous dose. That we have used along with remdesivir in a critically ill patient, that patients admitted to ICU only, who are moderate to severe category and are classical in cytokine storm. But we could not find any significant benefit out of it, or reduction in a cytokine storm, or early reducing the days of ventilators while we were using the interferon. And subsequently, there was no evidence coming out of it, so we have stopped using it. Hardly very few cases we have used, roughly around 20-25 cases at that time. To add to, but to add to about baricitinib, we were at that time looking for a steroid sparing agent, and the studies came up with baricitinib. Now, baricitinib we used in patients where we were very skeptical of using high dose steroid like methylprednisolone 40 mg/2. So we'll use baricitinib with remdesivir and with a low dose steroid, so that the risk of co-infections or a secondary bacterial infections was less. That was the thought process to use baricitinib, but that also we could not continue for a very long time, and we did not see any much benefit of using baricitinib also.
I'm sorry if I may ask, I mean, did you also face the same issue of secondary sepsis? Or was that something which you observed in your sentence? To all the panelists?
So secondary sepsis was phenomenal, and I would like to. We have quite retrospective data of our center, and almost around 148 patients we had a data with culture positive growths. So our standard regimen was remdesivir steroids. So in the month of July or June, early June, we till May, the pandemic started in March and April. In May onwards to July, when steroids came, when tocilizumab started, we found sudden surge in infection. So we got most of our cause of death as a sepsis was the main reason for cause of death. Then we use 5-prong approach because this was going on till 6 months to realize us we are growing multiple infections, and most of the deaths are because of sepsis. So we use certain our measures, which with that we found out a significant reduction in secondary bacterial infections. And so number one reason was we started antibiotic stewardship, and that we were strict control of antibiotics, and without an infectious disease approval we will not change the antibiotics or add a broad spectrum second thing, we started using hypochlorite at a little higher concentration. Now 2.5% is the normal concentration of hypochlorite. So we started a deep cleaning of the unit with 5% hypochlorite at times, and that has reduced our incidences of enterococcus infection or fungal candida auris. There were a lot of such fungal and bacterial infections were coming, so that has reduced. Then we started avoiding using gloves, within the changing of gloves frequently. We started removing gloves. So we will work without gloves, and when you're touching the patient, only that time so we used to not use those gloves between the patients. So Gloves were only changed when you're going to touch the patient or when going to touching the cubicle of the patient. Otherwise, we will not use the gloves. So gloves was a very notorious thing which we found that causing a trouble in transmitting the cross infections. So these were the some of the interventions we did, and then towards 2021 June, we got quite hold on our secondary bacterial infection. The most common organism we grew, it was a group of Enterobacteriaceae in most of the patients. Then in fungus we got Candida as the major fungal infections, and very less gram positive. And in gram positive, we have most of them as Enterococcus. So we have statistically significant rise in Enterococcus infection during the typical COVID infections. So I think it is one of the game changer in patients who are in ICU on a mechanical ventilation. If we are not having a strict policy of infection control, as you rightly said, Dr. Chatterjee, that basic infection control practice and basic critical care was a main cornerstone to save few lives towards the later stage of pandemic.
So there is one.
Any role of cytokine removal with the filters like cytosol filters and Torre filters being used with CRRT. So even Dr. Charugat, I think you must have used a lot of filters for the CRRT. Those patients we have
Yeah.
there.
So no, not you. I mean, see a lot of AKIs and CRRTs, but we haven't really used cytosol. The evidence is poor even in the normal septic setting, because what it's not just removing the bad cytokines, but the good cytokines also would be removed, right? So not entirely sure about the benefit. We haven't really used those that kind of filters in this setting for sure.
There is one questions like the use of fluvoxamine from one of the delegates. So the thing is that Dr. Diptis has put one literature on that. So can you just elaborate, Dr. Diptis, the use of fluvoxamine?
Yeah, so there have been trials in use of fluvoxamine. So it's not, it hasn't been shown to be very effective in the acute phase. But because of its other properties related to the in the management of anxiety and other things, it's still being explored whether this can be a good choice for treating the long-term symptoms of COVID-19. And there are a few trials ongoing. So there, it's not like a completely not recommended. People are still using it, but for the purpose of managing the long-term symptoms, like especially the respiratory and the neurological symptoms.
Okay. One question from Dr. Masood on take on tocilizumab in early moderate to severe COVID to Dr. Lakshman, and what is the doses recommended?
Yeah, during the second wave, we had used a lot of tocilizumab, but again, it told you that is to be in a selected group of patients who are not improving despite giving steroids at optimum doses. So if you are giving steroids, no improvement, category C patients, severe patients, in those patients, we have tried tocilizumab, but tocilizumab has a very high secondary infection rate. Like Dr. Charudat mentioned regarding a secondary sepsis, it has a very high secondary sepsis rate. So we have to use tocilizumab in only a selected group of patients. The dose is 8 milligram per kg and not to extend more than 800 milligram per day. A single dose of tocilizumab is sufficient. However, there is literature to suggest that if there is no response with one dose, you can use second dose. But preferably, we only give one dose of tocilizumab and see how is the outcome. But I think baricitinib has actually been a substitute for tocilizumab. Instead of going for tocilizumab now, if the patients are not improving on steroids, we are giving baricitinib. So I think the usage of tocilizumab will now come down.
Okay, thank you. One more question is like in the month of January, I think the third in the third wave, basically molecules like 2-deoxy-D-glucose has been came in the market. So any experience on that, like Dr. Charu or Dr. Ketan? 2-deoxy-D-glucose.
No experience. No experience about it. Okay, Dr. K.
At our center, we have not used it.
Anybody, Dr. Diptes? I think you are muted.
Sorry, no, we haven't used that as well.
Dr. Lakshman?
No, we have not used it, and I think it's a gimmick molecule. It is just ultimately a glucose, and they have not come up with any studies. They did not show how is the efficacy, and I don't think it is there, and that's why it has not come into the algorithm of various societies. There is no recommendation of 2DG amongst various societies by NIH, CDC, IDSA. So I think it's a gimmick molecule. I think we should just ignore it.
This was tried for the cancer patients, considering that it will cause deprivation of the oxygen to the tissues, and similar effect can be seen with the COVID-19 infection. But the data, the small little data that was published, it has not shown any outcome benefits, particularly with these preparations. So that's why it has not become popular and probably not recommended in guidelines also. I don't think there is any role to use it COVID-19 infection.
So with this, I think one or two questions. We have another panelist, Dr. Santanu. Actually, Santanu was busy in some clinical work. Dr. Santanu, if you are there. Okay. So I think with this, with no more questions, so can we wind up the sessions, or anybody has anything? Take any take-home message for our DNB trainees and the fellows for the upcoming exams regarding COVID.
I think I just wanted to add. I mean, one of the things which could potentially come up is about the pediatric COVID. Though we are all adult physician, but that group and how the COVID affects, and the syndrome associated with pediatric is something we probably should know as an exam point of view. And of course, I think this particular lecture and Dr. Lakshman's overview of COVID is extremely comprehensive. I think there's nothing more to say beyond what he has said. And I'll say all the best to all the students.
Yeah, I think we are talking about the MIS.
MIS, yeah.
MIS. So how frequently you see in adults? You have any experience?
No, I mean, I'm just saying from the exam point of view, even something the students should be aware of, because that's a syndrome which could potentially be asked in the exam.
So one more question is like LLLT in COVID-19 from Dr. Rakesh. Is this any newer molecule, LLLT?
Not sure what it is.
Not sure. So it is one of the newer molecules. He's saying it's a newer molecule, but probably I don't think anybody has used it.
Not used.
Low-level laser therapy. The full form is low-level laser therapy. So these are all, I think, the experimental practice. So it's Dr. Diptes has some put one literature on that. If he can highlight.
Yeah, so this is a living document which is constantly being updated and published in BMJ. So for our colleagues who may not be aware of these resources, this is really helpful. The infographics are really useful, and it's constantly upgraded and based on different clinical trials, meta-analysis, and network meta-analysis. So I just said it for our colleagues who may be preparing for exams or may not be aware of this resource.
So is it a resource you meant to say?
Yeah, so yeah, this guideline is really useful for learning more recent advances on therapeutic options for COVID-19.
Okay. So it has received successful results in 561 active cases. Okay. So if with the interest of time, I think let's wind up the today's session. I think it's a very wonderful session by all the panelists. I thank all the panelists, delegates, and my co-colleague Dr. Akhilesh. If anybody has something to say regarding any take-home message, otherwise we can wind up. And uh, again, thanks from our Navi Mumbai Apollo Hospital, and all the best to the exam goers and the fellowship students. Akhilesh, you have anything to say?
You have summarized everything. Thank you very much, Dr. Lakshman, for your wonderful and very interesting session. I hope the students must have benefited a lot with these the slides that you have shown, and hopefully, if it is available to them, they would be very happy for their preparation. I would again like to thank Dr. Charudatta. Your presence was very important, and probably the insights that you have given is very, very useful. I thank you again for your presence and hope to see you again and again. And I again thank you, Dr. Ketan. I mean, we meet quite often, we discuss, but this platform, virtual platform, was meant basically for the students. And you've done the justice with the topic. And yeah, I think your experience of handling COVID-19 infection will be very useful information for the students. And not with, with Dr. Diptesh Aryan. We are meeting for the first time. Thank you very much for sharing your experience
Thank
with
you.
Nepal as far as handling of COVID-19 infection is concerned. And your published data will be very, very useful if you can share that data to our students, and probably, more and more such studies should happen. COVID-19 data collection is done at many places, but the data is just stored in the computer,
Yeah.
and it should be published. What is
Yeah.
important is we should publish. Unless we publish the data, we will not be able to really understand the disease. We have still not been able to understand the disease. We have been treating the disease blindly, but there is a lot more to learn, and probably the data that we have collected we need to analyze and really come up with some conclusions. Probably for that we all should work hard on statistical analysis and research that is going to help us. More and more newer therapies are going to come up, and that will come up only if we study and publish the data. With this, I thank you again, my colleague Dr. Shantanu also, and I thank Dr. Gunadhar for moderating this session wonderfully, and hope to see you again and again. Bye bye for now.
Next session we have on this. Can you just elaborate for the next session, upcoming session on Friday?
Yeah. The next session will be on ECMO therapies, BA ECMOs, BV ECMOs, and ECPR. The discussion will be on 17th, 7 to 8 p.m. And we have an international speaker, Professor Thomas Muller, who is pioneer in ECMO at Rosenberg Hospital, University Hospital in Germany. And with that, we have the Indian panelists and some of my colleagues who have pioneering work in ECMO. And they will also be able to share their experience of ECMO in COVID-19 infection. And hopefully, we will be able to learn a lot from the topic. And I would invite you all for the coming session on 17th. Please join us. And thank you, everyone, for today's session. And bye bye for now. Good night.
Thank you, and thanks to also Misbah and CCU team for providing this Zoom platform for organizing the session. Thank you.